Thank you, Dr. Bhavna, for the kind introduction and having me for this course. Yeah. So I will be covering the topic on emergencies which are associated with advanced corneal ectasia. So if you look into the emergencies which are associated with advanced corneal ectasias, we have eye drops, which can occur in keratoconus, pellucid, marginal degeneration, keratoglobus, and thin corneas, which don't fit into very typical description of any of these above. And they can also land up with ectasia. So these are the four conditions primarily associated with acute eye drops. Then we can have perforations, which can occur in pellucid marginal corneal degeneration and Terrien's marginal degeneration. Corneal tear subsequent to trivial trauma can occur in keratoglobus, and this is a well-known complication in this condition. So if we talk about acute eye drops occurs due to a split in the Duval's layer and the Descemet's membrane, and this leads to a sudden loss of vision, which causes significant morbidity. Though it is a self-limiting condition, the management is mainly aimed to achieve a quicker recovery of the symptoms of the patient. So management options remain conservative medical management in a vast majority, which is in the form of steroids, hyperosmolar eye drops. Intracameral injection of gases such as C3F8 and SF6 can be given for a quicker resolution. And in the more recent years, the compression sutures, either whether they are full thickness or partial sutures, have become the management of option of choice. If we look into the algorithm based upon the conditions where acute eye drops occurs, the management of keratoconus with eye drops, typically for grade 1 and grade 2, which means that the area of eye drops is less than 5 millimeters, the preferred management is conservative for about 1 to 2 weeks, and if there's no response, then probably maybe a surgical intervention might be required. Grade 3 eye drops, which is more than 5 to 6 millimeters dimensions overall, generally requires a surgical intervention for the quick recovery, and this is in the form of compression sutures. Pellucid marginal corneal degeneration, because it occurs because of a concentric split in the periphery, these are best managed, and because they're in the peripheral location, best managed with compression sutures with a very predictable refractive outcome as well. Keratoglobus generally should be managed only conservative and no intervention, because it is a difficult task to suture these kind of corneas. So the principle for the compression sutures is to flatten the anterior lamella and bring it in close proximity to the Descemet's membrane and the endothelial complex layer. So partial thickness is preferred because if you apply full thickness, it is really difficult to pass the needle through and through, and full thickness sutures can cause a fistulous tract at the time of suture removal, which may cause a problem. It can lead to more scarring, and it can lead to also tautness of the DM. So partial thickness works very efficiently, and this is judged by the amount of air in the anterior chamber. At the conclusion of the surgery, very minimal air is retained. It is really not required because you want to avoid using any kind of gases in the anterior chamber. So pre-op assessment is important to look at what kind of tear and where is the location of the tear. In some cases, we would be able to identify by the relative translucency through the cornea in the area of the eye drops. So in this case, though it's not very apparent both on the slit lamp on the OCT, in some cases we can actually see that in the area which is located in the center is the area of relative translucency, is a site of tear, and which can be also seen on the OCT. This is another case where there are multiple loculi, and you can see that the site of breach is in the center in the multiple loculi fashion, and same is picked up on the OCT as well. Intraoperatively, the site of tear can be identified using an endoilluminator or the light pipe, which highlights the things better using a sclerotic scatter. If you're using compression sutures, the guiding principles and strategies of suturing can vary based upon the location. Generally, the principal guideline is to apply the compression sutures perpendicular to the tear when you can identify the tear. However, there could be situations where the tear is not very apparent. In such cases, arcuate sutures from the periphery, starting from the periphery to the mid-center, is followed. This is later on followed by the center infinity suture, which is in the form of an overlay, so that we don't go through and through into the stroma. And these are the various patterns. In pellucid, because the tear is almost always concentric, in eye drops, we will apply radial sutures as is shown in the figure F. So this is one case of keratoconus with a 3 weeks eye drops history. We make a side port, and subsequently the air bubble in the anterior chamber gives the plane for passing the sutures, and initial 3 sutures have been taken arcuate manner from the periphery to the center, and in the center we place a figure of 8 or the infinity suture, where the sutures are in the overlay fashion in the center part of the cornea. And when we see that over after intraoperatively, this a gradual reduction of edema right at the time of sutures, because sutures also form the way of venting incision. We can see that some bit of clearing has already happened, and this is followed by a bandage contact lens application. And this is the post-op day 1 of the picture of the same patient, and day 3 we can see there's a remarkable resolution of edema on the day 3. This is one more case of Down syndrome. This patient presented 5 weeks later and had extreme photophobia and was very symptomatic. And for this reason, the intervention was undertaken. And in a similar fashion, sutures were applied. And when we, in such a large high drops also, it helps in remarkable resolution of edema intraoperatively and in the post-operative period as well by the similar technique. And this is at 2 months when the sutures were out. This patient had a relative clearing and did well after the resolution. This was one case of post-trauma related to a very thin cornea and ectasia. And if we can see the corneal picture, the corneal slit lamp findings, there is a relative area of translucency in the mid-periphery. And when we see the OCT, there's a split in the mid-peripheral region, and this was all circumferential. This case was managed again with the similar technique of applying sutures. And in this case, because the tear is almost like in the mid-peripheral area, the sutures were applied radial, and towards the conclusion of the surgery, this is how it looked like, because it's all circumferential kind of a tear. And this is the picture on day 1. We can see that immediately on the next day, there's a remarkable clearing because we have brought the sutures, we have closed a defect which is existing in the peripheral location. And this is at 1 week, the cornea is compactor. Similar thing for the pellucid marginal degeneration, where you have a tear in the periphery. The sutures are placed in a similar manner. And this is the pre-op and the post-op on the same day. We can see that the remarkable resolution happens. In pellucid, there's one more advantage of placing the compression sutures, is that it gives a refractive outcome also, whereas the area of the ectasia is sort of flattened, and then you can actually achieve a very good refractive outcome following this procedure. Pellucid can also be prone for repeat episodes of high drops, and this was one case where we see the red arrow is pointing towards an area of previous high drops, and then subsequently there was one more high drops occurred later in the superior location, again managed with compression sutures, and the last picture is that of a 1 week duration. Pellucid, there's one more important thing to understand, is one important clinical sign is that of an impending perforation, and there's certain sign which can herald a perforation. In this condition, apart from high drops, we can have a spontaneous perforation. So this was one patient who presented with a history of pain and tearing of 20 days duration. This is a very remarkable history in these patients, and if we notice this history, we have to be a little guarded and about the follow-up of the patient. This patient also mentioned that there was a rapid change in refraction and drop in vision with the glasses, and the refraction changed from myopic to a hyperopic refraction of +8 with 21/25. Now let's see what happens on the OCT. If we do the OCT in this patient, you will see that there's a relative area of reflectivity, hyperreflectivity, and this is the area where the stretching effect is happening, and as a consequence, there's a relative clearing which is seen in the center as marked in the arrows. And this patient presented with a perforation at 2 weeks, and this was managed with suturing. And following suturing, the patient has done well, and we are not going to remove the sutures because this is sort of improving the refractive error which the patient had. The unaided vision, which was almost like uncorrectable, has become almost with the proper cylinder, very minimal cylinder. The patient is doing well with the good vision at 8 months post-op. Terriens is again one peripheral degeneration which can land up with perforations, and many of these cases, which are smaller nature, we can manage with the patch graft, but some of the cases may simply do away well with the amniotic membrane or a Tenon's patch graft. In keratoglobus, generally these kind of cases present with the histories of very trivial trauma and landing with the corneal trauma, which is very difficult to manage. But there are some tips which can be just given for managing these cases. Would be when you have a tear, to manage in keratoglobus, taking a little longer sutures, mattress sutures, avoid burial of the sutures, using fibrin glue. These are few things which can be done to manage the corneal trauma in these cases. I won't cover in detail because we have a subsequent presentation. But prophylactic surgical measures in the form of epikeratoplasty, as is shown in this video, can be one way of managing some cases which have extreme thinning and are one-eyed, to preserve the globe integrity. Otherwise, some of these complications, when they happen, can lead to complete loss of vision and non-salvageable eye situation. So this was one case where already the patient had a high drops and cornea was very thin, and this was a pediatric child who had a very thin cornea and was one-eyed. So in this case, epikeratoplasty was done with the intention to see what is the refractive outcome, and thereafter, possibly when you do the epikeratoplasty with a normal thickness donor cornea, possibly if you have to correct, we can also do a central PK subsequently. But this case was managed and had a decent outcome with epikeratoplasty done for this child. So thank you. If there are any questions, I can take them now.
Thank you, ma'am, for this very informative lecture. And we very frequently come across such cases with the corneal edema and high drops, which we want to manage with the compression sutures. So, ma'am, what is the guiding principle here, that how many sutures would you apply and when do you want to remove those sutures, ma'am? After the, yes, resolving of the corneal edema.
Yeah, very good question. So the number of sutures will be whatever is bare required. It is not too many, but make sure that in the center when we are applying sutures, we apply it in a way that it is not going through and through. That's one thing. Second thing about the removal of the sutures, what you said is that in the peripheral part of the cornea, because the tear is in a smaller location, but the edema spreads all over. So in the peripheral location, the edema disappears far sooner. So they can be removed at usually around 3-4 days to 1 week time. But the one which is in the site of the breach, because the scarring and some bit of settling has to happen in the posterior membrane, those sutures should be removed ideally between 4 to 6 weeks time, depending upon when we see some bit of opacification and the posterior membrane.
Do we have any other questions from the audience? Okay, thank you, ma'am, for this
Thank
very
you.
informative.